So I'm going to be presenting dissociative identity disorder, which is also known as DID. So the diagnostic criteria for DID is usually categorized by disturbance in one's identity, signified by at least two unique personality states. Oftentimes, the host personality is usually unaware of the existence of other personalities for some time. Each personality varies greatly from each other and will present differently as well. So this could be like body language, even accents, just facial expressions, things like that. The disruption in one's identity will cause discontinuity in an individual's sense and of their agency. There's also going to be noticeable differences in one's affect, behavior, memory, perception, all of these things, which again, like throughout the different altered states. There's also a lot of amnesiac qualities, so there's severe memory issues and inconsistent gaps when trying to recall what had happened throughout even just that day, let alone the last week. And that's far beyond what's considered a normal amount of forgetfulness. So if someone had done something very significant the day prior, they may have no recollection of those events. These symptoms obviously seriously impede on the individual's life and cause significant distress in various areas, such as socially, interpersonally. They may not be able to hold a job down for very long, things like that. These symptoms also, and this is very important, are not attributable to substance abuse or medical conditions, and they're also not really broadly accepted by cultural or religious practice. And we'll talk about this later, but yes, like DID can really present to some cultures as like a form of possession or things like that, but it usually is a standalone like thing. So DID typically onsets at around age 12, but individuals usually don't really know what's going on with them until much later in life, unless somebody recognizes, hey, something's going on, and then they bring them in like to get assessed by a clinician. And it will usually come on due to traumatic events, childhood abuse, extreme overwhelming experiences, and it can manifest at any age, but it really does usually come on like adolescence, I guess you could say. Many times, like what I've found in my research is that a lot of the individuals that have suffered from this have extreme sexual abuse in their past, like incest and things like that. For children, it can present as memory issues, traumatic play, and traumatic play really just means like you're reliving the events that occurred to them or enacting situations that maybe are too violent or too extreme or too adult for their years. And they could have problems with attachment, concentration. There's usually no identity changes at this point in time. So for example, there's no real like altered states of personality. However, they could present with interference and overlap between mental states, along with symptoms related to discontinuities of experience. So it's like I guess kind of dipping your toe in the water of it, but you're not really switching too much yet. Older individuals may present as having mood disorders, obsessive compulsive disorder, paranoia. There's a lot of comorbidity with this diagnosis. It's also oftentimes confused for bipolar, schizophrenia, PTSD. And less than 2% of the population is diagnosed with this disorder. So impairment does vary widely from person to person. This is a very case-by-case basis type of deal. So for someone, they could struggle a lot interpersonally, whereas someone else could struggle a lot occupationally. With treatment, this may improve, and certain aspects that the individual struggles with can be targeted and helped. However, some individuals will respond slower to treatment than others. Also, throughout the course of being diagnosed with this disorder, symptoms can elevate and decrease spontaneously. However, DID does not just resolve spontaneously. It just doesn't go away and disappear. So that is something to keep in mind. Also, these individuals that are diagnosed with this can be grouped based on their symptoms. So the symptoms can be post-traumatic, and dissociatives, and these clients will likely respond well to treatment. Then there are dissociative symptoms mixed with symptoms of other prominent disorders, such as substance abuse, mood disorders, personality disorders. They may respond a little bit slower to treatment and have a more difficult time with their recovery, mainly just because it's a lot going on for them. And then there are some individuals that have very severe symptoms because of their coexisting diagnoses, as well as still having a deep emotional attachment to their abuser. So let's say that the reason that they, ended up in a tough situation was because of their mom. They may, because it's their mom, they may have still that very tight, close-knit bond with them. And so it's difficult to kind of treat, I guess the problem being their mom, if they still can't let go of that bond or see it for what it is. The treatment plan for these individuals is usually very intensive and very long-lasting and focuses on managing the symptoms rather than integration of the personalities. I also just want to bring up that according to an article titled "The Effects of Multiple Identities on Psychological Well-Being" by Amara Brooke, having multiple identities that the core self values and places a high importance on can be of some psychological benefit, at least if all of the personalities are harmonious and get along and perform their roles. The core self individual can come to rely on their altered states, as they provide each other with resources when they are all in agreement with each other. If the identities are not harmonious, then this can cause psychological damage. Some individuals may not want to integrate their personalities if they feel that they are dependent on them, and they value the relationship or the roles that other identities have. So I just personally feel as though it becomes a matter of how impaired is the individual, how much distress do these altered states cause the individual, and that's how treatment is looked at. That's why I said it's a very case-by-case deal. So males may not be forthcoming with trauma from their early life, especially if it entails anything having to do with sexual abuse. Whereas statistically, females don't really have this issue. And that can lead to misdiagnosis because in order to really have DID, there typically needs to be some kind of abuse or traumatic situation that has occurred in the past. So if the individual isn't open about it, a proper diagnosis can't really be made in full confidence, even if the professional feels like the client isn't being completely honest. You can't just assume things, Females present with acute dissociative states, whereas males will exhibit more violent or criminal behavior, just a little bit more aggressive. So females will present with amnesia, hallucinations, self-mutilation, and flashbacks, while males will just, again, become a little bit more aggressive when diagnosed with DID. And then also the environment and the culture that one is in plays a big role in the diagnosis and treatment of DID. So there are many cultures in which mental health is taboo, and that's not something to be discussed or to try and get help for. So if an individual who may have DID belongs to a culture like this, it can greatly affect their ability to get diagnosed and subsequently treated. Also, you have to keep in mind separate classes, right? So if someone is in an area where it's just very low income and they don't really have in that area a lot of resources because that's not where everything is targeted, it can be really hard for those people to, even if they want the help, to reach out and get the help because no one is really trying to make the resources available in those types of areas. Furthermore, there are also deeply religious and spiritual communities who believe in possession and supernatural phenomena. Due to the nature of DID, these two things will often present the same or close enough to the same that it can be mistaken for each other. If an individual comes from a family or a culture who believes in possession, they may believe their loved one is simply possessed and will want to go get an exorcist and talk to a priest rather than to try and get psychological help for them. So DID is now known as dissociative identity disorder, but it was formerly known as multiple personality disorder. And I believe that this change kind of took place once more researchers and psychologists kind of started learning more about this disorder. Also, theories regarding DID have grown immensely over the last few decades. Again, once more research has been taking place, and I guess also as things have become more sensationalized and more people started saying, oh, I have DID, I have DID, it kind of forced people to have to look into this a little bit more. And there is still a lot of like disbelief or skepticism regarding this disorder, but there has been a lot of growth, as well as cultural theories also need to be taken into account. So in an article titled A Review of the Dissociative Disorders, from Multiple Personality Disorder to the Post-Traumatic Stress Disorder by Romero Lopez Modesto, it was discussed that some of the early theories regarding DID ranged from supernatural theories, possession, reincarnation, to cerebral hemispheres disconnection syndrome. So it's kind of been like all over the place. DID originally classified in the hysteria section of the DSM-1. Psychological theories started in the 19th century with Charcot and Janet, and were later expanded by the likes of Freud, Prince, and Breuer. In its early days, DID was often associated with trauma and hypnosis, but no psychologist could really give a clear definition of the disorder. Like, no one really understood what this actually was and why it actually happened and what really was going on with it. And I think that's why a lot of hypnosis was going on. But also in my research, I found that when you hypnotize somebody with DID, you could also risk creating another altered state. You could just, especially if the person is susceptible to things like that. So due to a variation of symptoms, errors in diagnosis and treatment methods occurred numerous times in the early days as well. I also just want to mention, as these individuals suffered from amnesiac qualities and false memories, as well as a disrupted sense of self, there's a large amount of skepticism regarding this disorder. It was usually better tolerated and accepted when DID was proposed as the varying degrees of integration and identity rather than complete, whole, different personalities. I feel like the idea or the concept that your brain can just create 5 different people was a lot for people to believe. And so that's why there was so much pushback in the community. So identity confusion, amnesia, and identity alteration are at the core of this diagnosis, and these symptoms help to differentiate this diagnosis from others in the DSM. Depersonalization and derealization are common among individuals with this disorder, however, are not required for diagnosis. DID is heavily tested by using the SCIDD, which is a diagnostic tool used to assess for dissociative disorders across the board. Researchers from around the globe have found that this test, it has excellent inter-rater reliability as it's consistent across all cultures. Whereas the DES, the Dissociative Experiences Scale, which is a questionnaire, has translation issues from culture to culture. And as it's self-reported, different cultures may respond to symptoms of dissociation in a different manner. So this really shines a spotlight on the need to have some kind of uniformity and for there to be some kind of diagnostic tool where there is just a level playing field. As far as differential diagnosis goes, individuals can have both PTSD and DID, and that's mainly because those with DID have often suffered a great deal of trauma, so it's not unusual for them to also experience PTSD. When working with these individuals, it is critical that the clinician establish the presence of or absence of dissociative symptoms to concur if they have a dissociative disorder or if they're just suffering with PTSD. DID can also be confused with schizophrenia, oftentimes due to hearing voices, and this has also been sensationalized by the media. And it can be very difficult to distinguish a psychotic disorder from DID, but the difference between someone with DID hearing voices in their head is that they don't have delusional explanations for what's going on. Oftentimes, when someone has schizophrenia and they explain that they hear voices, they also have a delusional reason as to why they are hearing the voices, which makes it clear that they are dealing with a psychotic disorder. With DID, however, the individual is at a loss for why they are hearing the voice and won't make up irrational reasons to explain themselves. They may also personify the situation and say things such as, it feels like someone wants to write a letter with my hand, or things in the same vein. This doesn't really occur so much with psychotic disorders. It doesn't feel like someone is trying to use your body or like someone is using you in that way. DID can also be diagnosed from bipolar 2. Bipolar 2 can cause rapid shifts in mood, which is often present in DID due to the altered states of identity. However, in DID, this happens in minutes or hours, whereas with bipolar, it's much longer because it's a slower and gradual change in the mood dynamic. And then we also have to mention malingering and factitious disorder. So, like I was saying earlier, there are many people, even psychologists today, who still doubt the validity of this disorder, despite the rising amount of empirical evidence suggesting that it does in fact exist in, yes, a very small percentage of the population. However, with that being said, there may be people who feign having this disorder, especially having learned about it in movies like Sybil or more recently Split. These individuals usually will not report the lesser known qualities of the disorder, but will over-report and really play into the more sensationalized symptoms of the disorder. For example, an individual may feign having terrible amnesia and switch from personality to personality rapidly, but will neglect to mention depression or suicidal ideation. Some individuals may even enjoy the attention of having this disorder, to enjoy the idea of having the disorder in general. Taking a sense of pride in the number of personalities they have. So they could like the attention that they're getting for like, oh, I have this, or they could just enjoy the feeling of I have this disorder. Many of these individuals, however, lack the nuance to truly paint the proper picture of what it actually looks like to live with DID, and so they typically won't even get diagnosed with it, and rightfully so. So due to the nature of how DID onsets, it can be difficult to treat this disorder. Because it's typically associated with intense and severe childhood trauma, it makes for an uncomfortable experience in trying to help the patient. Even as far as investigating and researching DID, it's difficult to do so, as it forces the individual to relive their trauma almost. Because of this, treating individuals with DID is usually done with intensive, individualized psychotherapy, where the clinician can form a strong therapeutic alliance with each of the personalities. Treatment is usually done in therapeutic phases. So phase 1 will consist of working towards safety and stability. Phase 2 has individuals maintaining their stability while also exploring their trauma. And phase 3, there's an emphasis on then integrating the identities. Throughout these phases, it is recommended that there are interventions or supports provided to the individual, such as increasing awareness and tolerance of emotion, providing psychoeducation, developing impulse control, developing grounding skills, and again, working on that interpersonal relationships as well as the therapeutic alliance. There has been controversy that the phasic treatment model can re-traumatize individuals or even make them more dissociative. For example, even creating a new personality. This is due in part because the clinician would be engaging directly with the altered self states and having frequent interaction with them. However, in a study by Bethany Brandt and Richard Lowenstein of the Journal of Trauma and Dissociation, this method of treatment has proven to significantly decrease the amount of voices the individuals heard and the frequency in which they felt like different people. Also, many professionals agree that due to the duration of treatment and the lack of hospital resources, it just simply isn't feasible for individuals to be treated in inpatient settings. With that being said, due to the high comorbidity rate that goes with this disorder, it's not unlikely that these individuals will end up being hospitalized anyway for suicide attempts, substance abuse, anything like that. But to find a clinician that says, oh, my client has DID and they belong in an inpatient treatment, that just doesn't seem as likely in this day and age. So for the case study, we have George, who's a 32-year-old white male, and he's estranged from his family. He has lived on his own since he was 15 years old. He has discussed experiencing intense sexual and physical abuse as a child to one of his previous therapists. He states that this is the reason that he left home at such an early age. He often finds that he has large chunks of his day missing and will wake up with no recognizance of what he was doing prior. He prefers not to discuss his trauma and has lately started to drink heavily. His drinking has landed him in an inpatient unit where he has been observed to be having several flashbacks. When questioned about these flashbacks by clinicians, he informs them that it felt like he was reliving events that he had been through, but it was as if he was someone else when he was involved in the situation. And then he was suddenly back in the inpatient unit. It was like he just woke up. So as we see in this case study, this isn't really as sensational, right, as one like you'd see in the movies. Like, again, in the movie Split, there's not really like altered body languages or different voices or accents or anything like that. This case study focuses more on the amnesiac traits of the disorder, as well as the co-occurring substance abuse that often occurs with DID. Because again, there's always usually going to be that like comorbidity. So they could have PTSD, they could have depression, things like that, self-harm. So the differential diagnosis a clinician could give with this case study could be PTSD, due to the fact that he has suffered a lot of trauma and now he doesn't prefer to talk about his trauma, but he's drinking instead and he's having flashbacks. So there's a clear path here as to why DID can often be confused with different disorders.